It's whispered about as the silent killer, the cancer with the lowest survival rate of all major cancers. For decades, a diagnosis of pancreatic adenocarcinoma has carried a weight unlike any other, a perception of near inevitability. But what if that perception is on the brink of a radical change? The truth is, pancreatic cancer has been cured, not for everyone, but for that crucial 15 to 20% of patients whose tumor is caught early, isolated, and surgically removed. The word cure is not a fantasy. It is a hard-won medical reality. And as we stand in January 2026, a seismic tremor is moving through the world of oncology, a breakthrough from a lab in Madrid that didn't just shrink tumors in mice. It eliminated them, without relapse. This isn't just another incremental step. It's a blueprint for a new kind of attack. So, is pancreatic cancer curable? The answer is a layered, anatomical yes, but yes, for a fortunate few through brutal, radical surgery. And potentially yes, for many more in the future, thanks to a triple drug combination that has just passed its most critical pre-human test. The but is everything in between: the late diagnoses, the biological fortresses, and the race to turn a stunning lab result into a human therapy. Today, we dissect it all. First, we must understand the enemy's origin. Deep in your abdomen, behind your stomach, lies the pancreas, a dual-function organ, both a digestive enzyme factory and an endocrine gland producing insulin. Cancer arises in its ductal cells. The genesis is almost always a mutation in a gene called KRAS, a molecular switch that gets stuck in the on position. This single error orders the cell to grow, divide, and ignore stop signals. But KRAS alone isn't enough. It recruits accomplices. The tumor manipulates its surroundings, forcing normal cells to build a thick, fibrous barrier around itself, a wall of scar tissue called a desmoplastic stroma. This is not just protection. This is the tumor's superpower. This stroma is a biological fortress with three deadly functions. 1. It physically shields the cancer cells from chemotherapy drugs. 2. It compresses blood vessels, starving the tumor of oxygen, which ironically makes it more aggressive and drug-resistant. 3. It creates an immunosuppressive mode, deactivating the body's T cells that are sent to kill it. This is why chemotherapy so often fails. The drugs simply cannot penetrate the castle walls in effective concentrations. So how do we cure it today? The only definitive answer is complete physical removal. Enter the most complex routine surgery in oncology, the Whipple procedure. It is an anatomical masterpiece of reconstruction. The surgeon removes the head of the pancreas, the duodenum, the gallbladder, part of the bile duct, and sometimes part of the stomach. What remains is meticulously reconnected, a Roux-en-Y anastomosis, to restore digestive continuity. It's a 5 to 8 hour marathon with significant risk. But for those who qualify and complete it, followed by 6 months of adjuvant chemotherapy, the 5-year survival can reach 50%. In oncology, that number isn't just a statistic, it's a beacon. But the future may not lie in the scale of the incision, but in the precision of the molecule. This brings us to the January 2026 headline. The team led by Dr. Mariano Barbacid at Spain's CNIO didn't try to storm the fortress. They designed a 3-pronged siege to dismantle it from within. Their triple drug therapy targets the ecosystem drug 1, a KRAS inhibitor, the long-sought-off switch for the master mutation. Drug 2, an immune checkpoint inhibitor. It takes the brakes off the body's T cells, unleashing them into the tumor microenvironment. Drug 3, a strategic chemotherapy agent, to clean up cells weakened by the first 2 assaults. In mice with aggressive human-like pancreatic cancer, this combination didn't just slow growth. It caused complete regression. No visible tumor. No recurrence. The fortress was not breached. It was dissolved. The critical disclaimer, and it's a massive one, is that this was in mice. The journey from mouse to human is fraught with failures. Human biology is more complex. Toxicity can be different. But this isn't just a single drug. It's a rationally designed strategy. It attacks the problem at multiple, validated points simultaneously. Clinical trials in humans are the next essential step, and the global oncology community is watching with held breath. So, where does this leave us today, in early 2026? For patients and families facing this disease, the present is defined by 2 parallel paths. Path 1 is early detection. Knowing the vague symptoms, new onset diabetes, jaundice, deep back pain, unexplained weight loss, and advocating for high-risk individuals, those with family history or genetic syndromes like BRCA, to undergo screening with MRI or endoscopic ultrasound. This is how we get more people into that curative surgery group now. Path 2 is the pipeline. It is the relentless march of science, exemplified by the CNIO trial, by improvements in neoadjuvant therapy to shrink tumors before surgery, and by the growing use of genetic profiling to find the 5 to 10% of patients who can benefit from targeted drugs today. The word cure for pancreatic cancer is no longer theoretical. It is a current reality for a minority and a tangible target on the horizon for many more. The fortress walls, once thought impenetrable, are finally showing cracks, and science is building the tools to bring them down for good. Stay curious, stay informed,